Good afternoon, everybody, and welcome to this webinar that is being jointly hosted by Anchor Excellence, Macquarie University, BESTMED, and Choice Aged Care. Antimicrobial Stewardship in Aged Care is the title of this presentation. Before we commence, it's only right that we acknowledge country, and in the spirit of reconciliation, the Anchor Excellence team and its associates acknowledge as the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past, present and emerging, and of course extend that respect to all Aboriginal and Torres Strait Islander peoples today. So what are we going to look at today when we look at antimicrobial stewardship? My name's Irene Stein and I'm from Anchor Excellence, and I'm joined by Christine Mueller, who's a well-recognised pharmacist, and by Amanda Fieldhouse, who's a clinical specialist with BESTMED. Christine comes from Choice Aged Care, and as I said, Amanda is from BESTMED. Today, we're going to have a look at what antimicrobial steward is in the context of medicine stewardship. We're going to tell you why it's very important and how it relates to the strengthened aged care standards and the risk-based questions. We're going to look at who can prescribe and the expectations for prescribing. We're going to look at monitoring protocols, their usage and their effectiveness, and we're going to conclude with a case study related to urinary tract infections.
Thanks for that, Irene. I think before we start discussing antimicrobial stewardship, it is important to define medicine stewardship in general. So stewardship simply implies careful and responsible supervision of an important resource. Thus, medicine stewardship refers to the careful and responsible supervision of medicines. More specifically, it refers to coordinated strategies and interventions to optimize medicine's use, usually within a specific therapeutic area. So appropriate stewardship of medicines is essential to ensure the quality use of medicines that meets an individual's needs while minimising harm to the individual and society, with an aim to improve overall health outcomes for the whole population. It does require a collaborative approach of the whole healthcare team as well as consumers, and is often broken into specific medications. So I'm sure we're all very well versed in psychotropic stewardship programs. Opioid and anticoagulant stewardships are other well-established areas. However, this being Antibiotic Awareness Month, we'll focus on antimicrobial stewardship. Based on the principles of medicine stewardship, it makes sense that antimicrobial stewardship, or AMS for short, is a collective set of strategies to improve the appropriateness and minimise the adverse effects of antimicrobial use, including resistance, toxicity, and costs. Furthermore, it balances the need to detect serious infections and commence timely treatment with avoiding unnecessary antimicrobial use. So stewardship is achieved by promoting the selection of the optimal antibiotic regimen, dose, duration, and route of administration. As we move on, I think it is important to recognise that AMS in aged care can be more challenging than that within acute hospitals due to the logistics with maintaining a home environment for consumers. However, we do want to ensure that we are using evidence-based tools and guidelines to assess for signs and symptoms of infection, as well as choice of antimicrobial if a prescription is necessary. That we are reviewing prescribing and trends, including a regular review of prophylactic antimicrobials. That we are ensuring documentation and medication charts are optimal. That we are using microbiological testing prior to prescription wherever possible. And that we're implementing effective infection prevention and control practices.
Thanks, Chris. We're going to look now at what is the importance of antimicrobial stewardship. Antimicrobial stewardship is important to reduce, as Christine has pointed out, the inappropriate use of antimicrobials. reduce the unintended consequences for the consumer related to the use of antimicrobials, reduce antimicrobial resistance to enhance clinical outcomes when they're really needed, reduce medication toxicity and interactions, and of course, all of that is going to enhance consumer outcomes and their well-being. Let's have a look at what antimicrobial resistance is all about. Inappropriate and overuse of antimicrobials contributes to the emergence of resistant bacteria. The World Health Organization refers to antibiotic resistance as one of the greatest threats to human health. Care recipients with antimicrobial resistant infections are more likely to experience ineffective treatment, recurrent infection, and with that, delayed recovery or even death. Along with infection prevention and control, hand hygiene and surveillance, antimicrobial stewardship is considered a key strategy in local and national programs to prevent the emergence of antimicrobial resistance and to decrease preventable healthcare associated infection. So how does this all relate to the aged care quality standards? And we know, of course, that from 1 July next year, we'll be looking at a different set of standards, and we'll be coming to that shortly. But under the current standards, Standard 3, Personal and Clinical Care, Organisational Requirement 3G, is about minimisation of infection-related risks through implementing standard and transmission-based precautions to prevent and control infection, and practices to promote appropriate antibiotic prescribing and use to support optimal care and reduce the risks of increasing resistance to antibiotics. Further, Standard 8, which we know is the Organisational Governance Standard, and Requirement 3E, it actually calls out antimicrobial stewardship. It states where clinical care is provided, a clinical governance framework that includes antimicrobial stewardship, minimising the use of restraint, and practising open disclosure must be incorporated into your clinical governance framework. So how does all this relate to the strengthened aged care quality standards that will become part of our realities on the 1st of July next year? If we just do a quick overview of these standards, Standard 1 is the person. And of course, when we talk about the person, we focus on choice and dignity and consent. So no prescribing without those three considerations in play. We look at Standard 2, which is the organisation, particularly 2.8, which is about workforce planning. And here we're talking about having the right people in the right place at the right time to do the right thing. 2.9 is human resources management. And again, this relates to appropriate knowledge and skills for all staff involved in medication delivery and management. We then move on to Standard 5 in the new context. 5.2, preventing and controlling infection in clinical care, and 5.3, safe and quality use of medicines. I'm now going to hand back to Chris.
Lovely, thank you. So I guess as Irene mentioned about prescribing antimicrobials, it is important to look at who can actually prescribe. You know, our main ones definitely are medical officers, including general practitioners, but there are also many other people in aged care that we see prescribing antimicrobials. That being nurse practitioners, dentists, podiatrists, all have authority to prescribe. Pharmacists and even the consumer themselves or friends and family can provide or request over-the-counter antifungals and other agents. So what are the expectations around prescribing? Here I do want to acknowledge that engaging prescribing health professionals in AMS in aged care can be challenging, as they're usually visiting service providers that aren't remunerated for AMS activities and are working under considerable time restraints. So having said that, it is important that no matter who prescribes, we do need to follow the clinical care standard. So firstly, we need to ensure that anyone with a life-threatening condition due to a suspected infection receives appropriate antimicrobial therapy immediately. So secondly, that antimicrobial prescribing is done in accordance with the current therapeutic guidelines or evidence-based, locally endorsed guidelines. Thirdly, we need to ensure that all adverse effects of allergies to antimicrobials are reported and documented appropriately in the consumer's medical history and on their medication chart. So information about the active ingredient, date, nature, and severity of the reaction should be documented. Where possible, microbiological testing needs to be done prior to commencement of therapy. It is acknowledged that this isn't always possible. As with all care, the consumer needs to be provided with information about their condition and the treatment options in a way they can understand and be included on the decisions made, leading to that first standard of the strength and quality standards. According to a Cochrane review, shared decision-making, or including the consumer in that decision, does reduce antimicrobial usage. If an antimicrobial is commenced, the indication, active ingredient, dose, frequency, route of administration, and intended duration or review plan is documented. And Amanda later on will discuss this in more detail and some things that can be done to assist with this. We also need to ensure that regular reviews are conducted of all antimicrobials used. And finally, any use of antimicrobials prior to surgery for prophylaxis are done strictly in accordance with the therapeutic guidelines. So guidelines were mentioned a bit in those standards, and all our prescriptions should be directed by guidelines, both the therapeutic guidelines as well as local guidelines. So this here is actually a snippet from the therapeutic guidelines, and these should be available at the point of prescribing and can assist with decisions on the drug, the dose, and the duration. So furthermore, this snippet helps to assist when an antimicrobial may be indicated for a suspected UTI. So this snippet is taken from the therapeutic guidelines again, but you may also recognise the flowchart from the TDIP or not TDIP program. So use of the TDIP or not TDIP has been shown to reduce antimicrobial prescriptions in aged care, and does so by assisting the implementation of guidelines, such as the therapeutic guidelines, around when and when not to investigate for a UTI and how to investigate. I'll now hand over to Amanda to continue to discuss about why guidelines are important, and particularly in relation to UTIs. Thanks, Amanda.
Thank you, Christine. As Irene said, I'm working with BESTMED. BESTMED is an electronic medication management system, which is now in over 850 residential aged care facilities with continuing rapid growth. And the system is used by over 6,000 GPs and more than 1,500 pharmacies. So we have a lot of data sitting in the BESTMED system. Christine's talked about the balance between the need to detect serious infections and commence timely treatment while avoiding unnecessary antimicrobial use. I just want to mention here that BESTMED is delighted to be partnering with Macquarie University on a research project into the development and testing of a decision support tool for providing antibiotics for urinary tract infection. And we're looking to expand the current antimicrobial stewardship tool module within BESTMED to support antibiotics prescribing for UTIs. I'd briefly like to thank Macquarie University for permission to use their data in this webinar today. So, antibiotic use for UTIs is a recognised issue. We know that antibiotics for UTIs in aged care are among the most used medications with high levels of inappropriate use. Almost 1/4 of all antibiotics are used in residential aged care for UTI or a suspected UTI, and the McGeer criteria suggests that approximately 88% of courses were inappropriate. Thanks, Christine. According to the Aged Care National Antimicrobial Prescribing Survey, There's prolonged duration of antimicrobial prescriptions and prophylactic antimicrobial therapy, especially for UTIs. Cefalexin is the most common agent being prescribed for cystitis, but it is in fact a second-line antibiotic, not a first-line. Research also showed there's incomplete documentation of indication and review and stop dates. Thanks, Christine. Duration of treatment. This information has come from BESTMED data, and it's showing that by far the majority of antibiotic courses in aged care, up to 93%, are prescribed for longer than the therapeutic guidelines recommendations. Next slide. UTI decision support targets. The aim of designing a decision support tool is to improve prescribing for common UTIs by providing an interruptive alert with appropriate empirical treatment choices, providing an alert with appropriate treatment duration, and guided decision support on appropriate dose and frequency. In doing so, of course, and looking to build this tool further, we are seeking to minimize clinician burden. We want them to use this tool, so we need to minimize the use of clicks they'll have to make. Next. UTI decision support targets. We're also working with Macquarie to further improve prescribing and support surveillance and reporting. We're seeking to incorporate the dip or not to dip pathway, ensuring that this information is available to prescribers at the point of prescribing. Next slide, thank you. Expectations around prescribing. We all know the importance of documentation, and these are considered the elements most important in the prescribing of antimicrobials. And the following should be documented for each antimicrobial prescribed: the indication, active ingredient, the dose, the frequency of administration, route of administration, intended duration, the review plan, and then the plans for therapeutic drug monitoring if this is required. I'm just going to take you through a few slides which show you the current antimicrobial stewardship tool in BESTMED. We're looking here when a doctor is prescribing an antimicrobial, the information, the tool that they have to go through in the BESTMED system in order to be able to prescribe. Here we can see the doctor's prescribing amoxicillin 500 milligrams and is doing it as a short course. In there, it's mandatory to select a date range, and you can see the date ranges there. Next slide. Again, we have to have a start date and an end date, and it must show the route and the indication for prescribing. Thanks, Christine. The prescriber is asked for further information in regard to pathology. Have the pathology results been received? Has the antimicrobial been prescribed following clinical assessment only, which may be relevant, for example, with fungal infections, or will the pathology be collected post-order? Thanks, Christine. So alerts pop up here and show if pathology results have not been received pre-prescribing and referring to the antimicrobial stewardship clinical care standards. Next slide. And the last one here, if the pathology is collected post-order, then an alert pops up to review the therapy, and it requests for a date when this medication will be reviewed. Thanks, Christine.
Well, how do we apply all this information in our real life context? So let's have a look at Mrs. Isaacs. She's a lovely lady, Mrs. Isaacs, and she's complained of back pain frequency of urine, and she tells us that she's really hot and sweaty. She tells the care worker how she's feeling, and the care worker, aware of the escalation process, talks to the registered nurse about Mrs. Isaacs' issues. The registered nurse responds very quickly and assesses Mrs. Isaacs and escalates her assessment to the medical officer, who orders an MSU for pathology examination, so a midstream urine specimen. We use midstream because it's considered to be the cleanest type of urine that we can collect for pathology. While waiting for the results, Mrs. Isaacs is monitored closely for any exacerbation in her clinical presentation. So how's she going? How's she feeling? She's given additional fluids and some Panadol for comfort. And this is given to her with great outcomes, and she's feeling much more comfortable, and her frequency has decreased. Her pathology returned a negative result for any pathogens at all. So she did not have a urinary tract infection. So no antimicrobials were required, and she recovered fully within 48 hours. Take-home message: to dip or not to dip. In her case, it wasn't necessary to do a urinalysis. The medical officer preempted by ordering pathology on a midstream urine specimen. What we noted here, though, for Mrs. Isaacs was the escalation process was really vital for quick action. So it's important as clinicians that we really do identify quickly what's required and escalate to whatever clinician is needed as soon as possible. Again, no urinalysis, no antimicrobials, and we used open disclosure, which, if we cast our minds back now to Standard 8, when we talk about any sort of clinical pathway with any consumer, we have to use open disclosure, and that means that we're open and honest and transparent in our communication with the consumer or their substitute decision makers, so that everybody is crystal clear about the clinical pathway, and in Mrs. Isaacs' case, the reasons why antibiotics weren't prescribed at the time that she made the complaints, her health complaints, known to the care staff. So a great outcome for Mrs. Isaacs, and of course we use the to dip or not to dip flowchart to get to this point. So we're going to wrap up. And in summary, antimicrobial stewardship refers to the ongoing actions by organisations to reduce the risks associated with increasing antimicrobial resistance and to extend the effectiveness of all antimicrobial treatments. It requires everybody's involvement and understanding of what antimicrobial stewardship is, and it also involves education for your consumers and your substitute decision makers, so they fully understand also. And they don't have expectations that Mrs. Isaacs, for example, would have been given antibiotics straight away. And we know programs have been shown to decrease inappropriate antimicrobial usage, improve health outcomes, and reduce adverse consequences. And these we've talked about: antibiotic resistance. We know antibiotics have some awful side effects on the gastrointestinal tract: diarrhea, nausea, vomiting, constipation. In terms of skin, they can perhaps have a skin rash. And of course, unnecessary costs related to the purchase by consumers or their substitute decision makers of the product. Look, we just want to thank you for taking the time to be with us today and to celebrate this week. And we hope that you might provide us with some feedback. Please use the QR code. It won't take you very long, I promise. And we love getting feedback about the content, and also to give us information about any other education of this nature that you would like. I'd like to thank the panellists, Christine and Amanda. We've spent quite a lot of time putting this slideshow together and presentation together, and everybody has contributed a lot of their time and a lot of their energy. So thank you very much. And we hope that you have a productive and safe week. Thank you.
Thank you.
Thank you.